Hello.
Hello.
So I put on a different, newer computer. Does this look better than the other day, or does this look the same?
You look younger or what?
I don't know. I thought it was a better camera on.
Yeah, but it has a better. What's the name? I have to. Resolution.
Yeah, should have resolution. Should have better resolution.
I have to connect my new camera.
What's the tree in the background? Should I have the tree? Is that better? I don't know. More this way, more that way. There we go. I don't know. I've got two computers. I've got who knows. So we have 2,000 people on already.
I don't know. We will see how many will show up, but a lot of people noticed the webinar, so there's some attention on it. Just at the end, I would like, yeah.
So I can switch computers, but I sent you 2 slides. I don't know if you want to pop them up on your screen when I start talking, so that people can see the links.
Because I put the link, I sent you an email, you didn't receive it. I put the links on the website, and I have the announce here that they see our website on the Resilience Association website. I in the introduction.
Well, I mean, we can skip them. It just gives people links if they're asking, if you know, right there. So just another path as I'm talking, they can pull up and look at these things. The I don't have it on this new computer. So
I have it. I just let me take.
Actually, I can send it over and open it up if you want to share screen.
Hello. Hello, Bruria. Oh, it works. Okay, now maybe I can put this here.
Why can't I hear you through? Can you hear well?
Yes, very good.
Okay. How are you, David?
I'm fine. You know, we're not as nice for gardening today as it was yesterday. Suddenly? That's what we focus on here at springtime. Yeah, I can hear you.
Good. Okay. So you froze for a minute.
Oh, weird.
Probably my Wi-Fi.
Anyway, Ivonne, so I don't know. We don't have to use those. I am just making sure I can put it up on the computer I'm using now.
Checking the timing so we start sharp. Oh, I got a WhatsApp message. Okay, waiting. Okay.
Yvonne, do you want to maybe check if the Q&A works?
Rose, can you put a question there? Rose is not connected yet, but Gesa is there, or Milena? Let's see. Yes, I can put some questions. I can do it myself too. Oops. Okay, she's there. Can you put some questions, Rose? In the chat. Okay, she put it there. Let's see. Test. Yes, Milena. Thank you, Milena. She's putting a. Now it's there. So I see the chat. I have the chat here. So, and then we have 13 participants. How to put the participants? Okay. So,
Okay. So now we know that the Q&A works.
yeah. Ah, maybe I can put in the notes the links or.
Q&A, no open questions. Chat. Oh, so we're going to get the questions through chat?
Yes, that's the idea. So they can put questions while you are talking, and when we finish, I can do the host thing.
But I don't think it's through the chat. Do you see to the left of the chat, there's Q&A? We
Yes,
have both. We have
Windows.
Q&A. Do you see, David?
Yeah.
Put in the chat a question, but we have also a question and answer. Okay. Why is okay? From me to all panelists. No, from me to, sorry. I think everyone can see a question, but the chat is just for the panelists. Okay. Okay, so Tarcisio, it's best that you put the question in the question and answer window. I need to update this. I think.
Well, Tarisio put something in chat. Why did he see it?
Yeah, because I said chat, but it's in the question and answer. Please press not chat in the call and answer. Guess is the one who is very. I think everyone. Okay. Maybe it's best to put the questions in the question and answer functionality. Q&A. Yeah. Okay. So So maybe we can see the Tarcisio questions to start the discussion. According to the actual situation, what is the challenge faced in the countries regarding resources and information sharing? Okay. We can take that as the first one. Control C.
Ivonne and David, do you want us to, before we start, to agree upon David's suggestions on putting only the speaker and on the screen, and we actually didn't find the way to do it. If we shut down stop the video, it shows the logo, but still doesn't put the speaker, the only one.
Okay.
On the screen.
All right. Well, we should at least mute.
Yes, we will mute each other. We are not talking, that we don't have feedback, and
it's just background noise, you know. I don't
Yes.
think anything. I'm in the sunroom, cut off from the world except the dog, so I think she's pretty quiet. So, but who knows what strange things might happen. We've had bluebirds try to fly in through the glass before. So who knows what they do when they get excited in the springtime out there. All right.
We see a beautiful.
Well, we're up to 26, 3 minutes to go. I was hoping for at least 1,000.
you can look at the LinkedIn.
1,000 is for the next webinar.
Oh, we have 2 people recording?
What is the 2? Here is the 1.
I think if the other person tries to record, who's monitoring the questions, if she records, you just have to give her permission.
Okay, but Bruria, everyone has permission to record. Bruria, can you record? Or because Rose is not too.
For me, it looks, yeah.
Okay.
Yeah.
I did test the recording yesterday when we did the test with Bruria, but it's good that you mentioned that, Dave.
Okay, well, just want to be sure we have backup, that's all.
Mm-hmm.
And you too can, David, you can press on the bottom, the record.
All right, yeah. I thought we had to, when I've done it for these other ones, the host has to approve, I thought, but.
Yeah, but I configure, during the configuration, you can put that everyone can record.
Ah, good.
I did that this time and to see how it works.
Okay, great.
So.
1 minute, 39. People like to jump on at the last second.
And the question will be 15 minutes afterwards with Professor Woods. You were so good. It's Friday.
And Matthew is with us.
It was all a trick Friday, Ivonne, make you think I would stick to 15 minutes. You'll be waving your hands frantically at me and chatting at me going, what happened to 15 minutes? What are you doing?
Okay. The time, I have to check the time. Okay. So. Have messages and questions. Okay.
All right. The Matt says hi. All right. Time to go. Time to start.
Okay.
Me too.
Okay, I start now. So, good afternoon, everyone. My name is Ivonne Herrera. I'm the current president of the Resilience Engineering Association, and I will be moderating today's webinar on what knowledge, strategies, and practices do we have at hand to respond in a flexible manner to the COVID-19. On behalf of the Resilience Engineering Association, I would like to welcome all participants, in particular Professor Bruria Adini from Tel Aviv University and Professor David Woods from Ohio State University, who have kindly accepted to join this talk. The objective of this webinar is to explore and connect relevant practices, experiences grounded in resilience engineering and community resilience. We will start with a short introduction from David. Handouts are available on our website. We will then continue with experiences from Bruria and myself. In terms of logistics, please note that the talk is being recorded. To optimize audio quality, everyone except the panelists are muted. Please don't try to initiate your camera. In case of hacking and interruptions, we will record the session and upload it on the website. Please feel free to pose questions during the talk. To do this, use the Q&A functionality on the Zoom. We will read them and try to answer in the best possible way. The webinar is conducted as an informal talk, so all questions are welcome. Without further delay, please.
Thank you, Ivonne. So the question I want to pose is, what matters when we're in the middle of this evolving pandemic, particularly when it concerns many of the phenomena, findings, concepts, approaches, methods that we use, that we've developed as researchers, whether it's in disaster response, community resilience, resilience engineering, cognitive systems, analysis and analytics and data visualization, all kinds of things that we work on are here. But most importantly, we're in it, right? And at this stage, many of us know people who are seriously ill, some in ICUs. We know people who are preparing to care for the surge of patients, or perhaps even already caught up in some of the hotspot areas. So I want to cover, I've got two handouts, each of which are a 10-point, as compact as I can get, run through of what's going on to try to cut through the noise, the uncertainty, and the tremendous variety of communication, some of which are slanted on a variety of dimensions. So what's the key? The key is, what can we do when we're in the middle of this to reduce excessive deaths, right? The pandemic consists of a rolling series of outbreaks across the world. And that provides opportunities to anticipate, learn, adapt, and build and expand capabilities for providing care in areas that experience outbreaks later in the process. The key in this learning and adapting and acting effectively is to reduce excessive deaths, right? And everyone has roles to play, even small, to accomplish this. Now, when it's all over, just as in 1918-19 in the influenza pandemic, we will be able to go back and get some pretty good estimates of excessive deaths. In other words, what's the difference between places that handled this the best? And we can already see that playing out in parts of Asia that have broken the transmission cycles and built up the capability to handle the ill patients. Perhaps Germany right now as well is showing the way. But other areas will have death tolls that are much higher than the best anyone does. That's our excessive death rate, and we want to keep that as low as possible. That's the fundamental thing we have to keep focusing on. Now, how do we do that? Well, as we've laid out in resilience from the beginning over the last 20 years, it's about keeping pace, but at scale, and in this case, it's really at scale. Whether we're dealing within a large metropolitan area like Wuhan or New York, whether we're dealing with it on a region like Lombardy in Italy, whether we're dealing with at national or continental jurisdictions as this moves around the world. So we have two things that are going on in keeping pace. One is the rate of infections. And I have to say this over and over and over again. The outbreaks can't be dealt with until you get the transmission rate below 1, right? You have to turn around the transmissions of the virus that produce the need for hospitalization in patients. The sooner hospitalizations turn around, right, the less hospitals will get overloaded. Now, one way to deal with this, and we see a bunch of things circulating in a variety of parts of the world, the US, the UK, among others, one way to get the transmission rate below 1 is to do nothing. right? Eventually the virus starts to run out of hosts to infect because so many people have already been exposed to the virus. This is the do nothing baseline. And you sometimes see this circulating in estimates of 50 or 60 or even 70% of the population will be infected. This misses the points, all right? The question is, what effective actions break transmission faster? Which ones have the biggest impact on breaking it? Now, we actually know a lot about how to do that, right? And it's been evidenced in the work in Asian countries to break the transmission, build capability. Less so in some other parts of the world because we don't have the testing resources available to do the fundamental test, track, and isolate mechanism. Now, the second part of our keeping pace at scale is what actions expand our readiness to respond to patients needing hospitalization or ICU level care, right? If you're in the middle of coping with a surge, it's pretty difficult to build the capability to cope with the surge. That's fundamental. I mean, Richard Cook and I found this in studies of anesthesia expertise 30 years ago, right? Anticipating bottlenecks ahead, even if those bottlenecks may be low probability, allows people to build the capability to handle those effectively before they're trapped in the difficulties that presents. So we have to make the latter capability of building the readiness to respond match the rate of hospitalizations and patients needing ICU level care. Now, the other 10 points is from a second document. I won't go through too much right now, but it's available because it may be relevant to some of the questions and answers. Is that runs through what hospital systems are doing in order to build that readiness to respond. How this is novel, all right, and opens up it opens up reconfigurations along multiple dimensions and scales in order to handle this. You can look at the work of Xuan Chuang from Taiwan and her papers out there about studying beyond surge events to understand some of the factors that go on, even though this is going on at a much larger scale. Now, when there's so in expanding our readiness to respond, trying to break the transmission rate, the metaphor we've been using is steering through fog under pressure, right? Except it's multiple parties that are interlinked in multiple vehicles trying to make their way through the fog to get to the goal, all right, of reducing excessive deaths. When there's a mismatch between the capabilities and the demands, just as we laid out in the stress strain approach in 2006, 2008, right, we have worse outcomes, right? Excessive deaths. The ratio of fatalities experienced in a particular jurisdiction relative to the best performing jurisdictions. How much of a difference can we make? My current estimates is, now remember, this is going to change afterwards when people can spend months and months and months examining the data. But right now, in the middle of this, right, 4 times, right, conservatively 4 times, right? Wuhan might be a little less than that right now, given current data. What about 7 times, right? Spain is starting to exceed that in terms of estimating what might be the excessive deaths. How about 10 times? Well, Italy's probably well above that right now in Northern Italy. So we could make a difference from 4, 7, 10, maybe more times in the number of excessive deaths. That's what drives all of this. Now, what makes it difficult to deal with is in part the anticipation paradox. Effective countermeasures require actions in advance of the direct experience of tangible harm, right? If we wait till we start seeing ICUs slammed, if we wait till we start seeing fatalities rise, right, generating the capacity becomes difficult. And so we end up slow and stale, with later responses being even more disruptive to society and the population and less effective, as is playing out in places like the US and the UK. Anticipation requires ways of building that future responsiveness without waiting for the most definitive information. And it points to the key issues about where are we saturating the capability to respond in the medical system. And so our 3 fundamental patterns in adaptive system breakdowns become evident. And for success, we start seeing their opposites play out in the places that are doing the best. Now, there's another aspect of managing the risk of overloading and building the readiness to respond. And that is, we have a time delay, right? Part of what makes this virus so perfectly positioned to disrupt human activity at scale is the time delays. And it's always hard to control and manage and understand a process with time delays between when something starts and when the effects are seen. There are multiple time delays, and there are multiple points where decompensation at the physiology level, at the ICU level, at the hospital level, at the regional level play out. So many of these factors that we've studied and laid out are at work around us. When slammed, the key units in the hospital, right, they use up all their deployable capability, right? They have to mobilize more, and they have to have support from other parties to generate additional capability to respond, right? When we anticipate, right, the potential for a surge hitting a hospital or region, right, we start with different levels of hospital and society helping to generate the capability and mobilize so that it can be deployable as patients come in. We see this going on right now in canceling of elective surgeries, borrowing, reconfiguring. Again, look at the other piece with 10 of the 10 points talking about how that all plays out. In particular, what you see is new forms of coordination at new scales that are required to respond effectively. These upper echelons of organizations and society become part of the real-time tempo of operations, and they are not remotely used to being part of real-time, high-tempo operations. How do you get things to places at the right time? If they can't synchronize and synergize their response activities with the people at the front lines, mismatches grow and the excessive death toll will be higher. You see this right now in the shortages of personal protective equipment, PPE. You see this in some parts of the world, such as here, with the slow rate of scaling up testing that undermines the effectiveness of some of the best of the tools we have to break transmission. But you also see hospital systems adapting in a whole bunch of different ways. A lot of them ad hoc, a lot of them innovative in ways to build capability to respond, in part because they have to. As we've seen in Xuan's work, right, they will adapt as best they can. They will build capacity. They will try to take care of the patients in front of them. And we want to prevent that from getting to where they have to make terrible triage decisions. The global scale of the pandemic has shocked the as-is systems, certainly in the Western world. The scale of the challenge reveals the obsessive pursuit of optimality has undermined sources of resilient performance, resulting in severely brittle societies. We're not talking about a brittle organization now, some brittle processes. We're talking about it at the society level. And in some senses, that's what's new here. It's not that we haven't been scaling up in our studies and findings and understanding, but now we're operating right in a societal level, global level, in terms of the key factors about brittleness. The delayed and ineffective responses to COVID-19 reveal the cumulative brittleness that's hobbling the abilities of societies, nations, and jurisdictions to rise to meet the challenges. Now, that leads us to point 8 on my list, solidarity. And we'll see some more comments about this. Everyone is on the scene in this crisis. Everyone is at risk. Everyone is an actor in the evolving outbreaks. Everyone's actions have some ability to affect, all right, what will eventually be calculated as an excessive death toll. You can minimize it, everyone can, even if our actions are small, their cumulative effect, right, will show up in reducing the excessive death. Now, how do we synergize the social solidarity? And you see this in some of the issues of people clapping for the healthcare workers, other kinds of things, but this goes well beyond the standard epidemiological work and simulations that are projecting the scale of infections and so forth that you hear so much about. We should be emphasizing these other factors to build social solidarity. The next one, number 9, is moral agency. What is it to act morally in this crisis? Well, and it's, I think, very simple. Can you do something that makes a difference? Where making a difference means reducing the excessive deaths and supporting the people near or on the front lines trying to care for the sickest victims. If you can, then act, right? Then there's a moral imperative in my mind as someone who's worked in safety for 40 years to act to make that difference. Afterwards, we'll find out which actions were really the most effective compared to others, but we're in the crisis and must act on certain information, right? To not act is to make the decision, right? But not in line that we can make a difference. All right, acting against this moral imperative puts self above others and things above people, and then it also means that all of the likely measures of being effective in this crisis are likely to go way, way worse than what they could have been, given what we know at this stage in the middle of the response. Then the 10th point is what will allow societies to emerge, and in what form will they emerge from the crisis? How do they bounce forward as the pandemic resolves? How do they even start to resolve, right, and lessen some of the restrictions that are being taken to reduce transmission rates? Tom Seeger, Dave Alderson, and I have put together 4 criteria for societies to relax restrictions. Do you have the testing infrastructure at scale to test, track, and isolate as new cases emerge that could become new hotspots? This is what you're seeing going on in many of the Asian countries that have already blocked transmission. Second, do you have the capability to ramp up the healthcare capacity to provide treatments for all who become seriously ill while still providing essential care for non-COVID-19 patients? If you can handle the people who are sickest and give them the best chance of recovery, then we're ready to move on and set up society and its other ramifications after the experience of the crisis. But there are 2 more. One is, and these may play out in the longer term because of the time scale of producing these interventions. Can you provide safe and effective treatments to promote recovery for patients seriously ill from COVID-19? Do we have some treatments beyond the kind of mechanisms that are in play right now to support the respiratory system, given the physiological mechanism by which this virus challenges people and can produce fatalities? And lastly, can you create the ability to build immunity in the population and assess the immunity in the population through antibody testing and development of vaccines? Can we understand what kinds of immunities are out there and can we build those up further? But all 4 of these have to operate at an enormous scale. So those are the 10 points that I want to put out there, and I find myself repeating over and over again as different questions and communications, noise and uncertainty play out through this. Also refer to the other document you can download at the REA website or on ResearchGate to see the description of 10 points that capture the adaptations and processes that we have seen before that are operating now as hospital systems build their capacity to respond effectively for the sickest patients. Thank you.
Thank you, Dave. So, Bruria, do you have some points to add to Dave's presentation?
Well, first of all, I want to express my admiration, David, for taking such a complex challenge and trying not only to delineate what we're required to do, but also put out those 10 commandments, which actually make it much more facilitating for all of us to try to overcome this huge challenge, which the global community is now a part of trying to overcome it. I would like to expand it to 2 main population or 2 target population that I believe that we need to focus on in order to strengthen our societal resilience. The first, and maybe the foremost, is the population, is the public. As individuals, as families, as communities. We sometimes tend to consider them in the COVID-19 as the challenge, or even worse sometimes, as the problem. but they actually are a vital component of the solution. So as studies have already presented, we know that resilience is important in order to achieve community engagement. And in the present COVID-19 crisis, we need the community, we need the public engagement, because only their compliance with all the varied measures which we are directing, such as home quarantine or social distances or lockdown, we need to make sure that they understand and that they're willing to comply. So the individual, the community, and the national resilience are crucial in order to maintain the trust in the leadership, and subsequently to have everyone comply with these measures that are being conveyed, sometimes with very rapid and frequent changes. So we can actually relatively easy make an impact on these elements if we invest efforts in doing so. And I'll give an example. A few days ago, we exposed a representative sample of the Israeli population. It was 550 respondents to a 6-minute video film, very short video film, which we designed with the responders, which display what the coronavirus is all about, what are its symptoms, and what is the required behavior from the public. When we compared the level of knowledge and perceived knowledge, feelings of being protected, and the resilience among these sample of the population, we found a significant increase in all of these 4 components after viewing the film compared to the levels that they displayed before watching the film. So the level of knowledge, and even to a greater extent, their perceived knowledge, as well as feeling protected, were all found to be positively related to the level of resilience. So this is something which is relatively simple for all of us to do, and we can implement it very, very quickly to make an impact. There are additional elements that should be taken into consideration when we implement measures to enhance the population resilience. Some may think that during the current crisis, the levels of resilience will be low. We discovered some very interesting findings. As we expected, the levels of concern, the perceived danger, and the stress symptoms were higher than the baseline levels that we found before the corona period, while the levels of individual resilience were found to be lower compared to the pre-corona period. So this is something expected. But in contrast to that, what we found is that the level of both the community resilience and the national resilience were higher than the current crisis. So what does that teach us? What can we learn from these findings? First of all, we found that the level of resilience of each individual decreases due to the health, the economic, the societal risk that we're all exposed to. But we then, at the same time, look for support from our community as well as from our national leaders. We need to build on this and provide the support that is so much needed by empowering the population, explaining to them how they can help, even while they're staying at home, disconnected physically from their routine support systems, but they can be connected through other elements. So for example, we can relate to them how they can help to stay connected to all of those loved ones or the neighbors or others that may need this social contact through all the technologies that we know that are so easily at our disposal today. In order for the public to comply, they need to trust the authorities that convey their directives. What has been done in many societies, including to a very large extent in my society in Israel today, is to totally frighten the public by presenting devastating predictions. Thousands in the community will die. We will not have enough ventilators to provide you with intensive care. The police and maybe even the military will forcibly implement the lockdown. We've learned in the past from our studies that fear does not enhance compliance. On the contrary, it raises the level of denial, and thus we may actually achieve the opposite of what we're aiming to do. So what we need is an efficient risk communication campaign, without ignoring such predictions, but simultaneously empowering the public. Yes, by studying the coronavirus, we have no doubt that we shall be successful in overcoming it, but only if you as an individual and as a community are partner to this effort. You can contribute to the health and the safety of your father, your mother, your neighbor, or others by staying at home. We know from studies, as you mentioned, David, the solidarity, the community cohesiveness, these are all elements that rise during crisis. And a feeling of responsibility towards others will actually achieve higher compliance rates. I want to touch now briefly on another very important target populations. You mentioned the frontline responders. In this crisis, we're talking about the healthcare personnel mainly. So their representatives must have access to the decision makers. And here too, we need information, clear, consistent guidelines. It's crucial in order to gain their trust. For example, how can we explain to our providers that we are providing the emergency medical services with one type of personal protective gear, for example, N95 mask, while many of the hospital personnel that are also in direct contact with potential corona virus ill people are receiving just surgical masks. This is a discrepancy that we need to have clearly explained. Who are we providing with N95? Who are we providing with surgical masks? And why this difference is actually part of the policy when we emphasize that our first and foremost goal is to have these medical providers feel protected, that they're appreciated, and that they're considered when we're making all the policies. And this brings me to the last point which I would like to relate to, and that is who is managing the crisis. Okay, we're all talking about the healthcare concern, the health crisis and so on. But the coronavirus is not solely a public health concern. It's also an economic, a societal, at times even a political crisis, and as such should be managed and coordinated not only by the healthcare systems administrations, but rather as a holistic challenge involving many other stakeholders. For example, Ministry of Finance or Economy, Security, many more. Furthermore, globally, sharing of information and knowledge between our different societies, between the different sectors and so on, together studying the data that we can collectively gather, analyze the consequences, and collaborating even more closely, this will enable us all to combat the current hazard, the coronavirus. Only by centralizing and collating the added value of all of us, of all the stakeholders together, can an effective management be achieved, and then we will be able to do what you asked us to actually get as soon as possible to bounce forward. Thank you.
So thank you, Bruria, and thank you, Dave, and thank you both. It's the first time that you two interact in this time of talks, and you met for this interaction. I would like to highlight 3 points for the discussion to add on your points. And the first is the understanding of resilience, because we have conducted with Bruria and other colleagues around Europe, we conducted a study on diverse understandings on resilience. David had worked on that too. And today we understand resilience as the ability to continue operations when we face diverse conditions, taking into account both disturbances and opportunities. So we are talking about bouncing forward, as both Dave and Bruria mentioned. And in the case of this crisis, the world will not be the same. So we cannot bounce back. We are bouncing forward. And a second point is the studies that they have been conducted at organizational level. And it's about the resilience management. And these studies look at what is the organizational resilience that have a company. What are the strategies and the mechanisms that exist to handle a situation? There exist plans and there exist procedures, but as the situation change, these need to be revised and have questions around that. So there have been conducted some studies about looking into the sources of resilience to handle the situations, to revise the plans and the strategies that they have as new information comes at place. And this is to look at what is the adapted capacity, what are the roles that exist, what are the resources, do we need to change the roles that we have, do we need to put an additional resources, learning what goes well and also looking forward to act. And the third point is about bouncing back, innovation, and the use of the population. So what we have been talking is using the community, the industry, the actors that we have at hand to have new solutions. And we have some examples that in Norway, we have producer of sails that have changed his production, and instead to produce equipment for sailing, he's producing protecting gear. Another example that we have both from Norway is a production of aquavit, and he changed the production, and now he's producing disinfectant for the hospitals. These examples also is found in Sweden from the universities. And the last example that I would like to highlight is the use on social media, and how social media and hospitals in different parts in Norway, they are using social media to ask for additional resources, and the industries around are providing additional resources to the hospitals. So to conclude, these 3 points that I want to highlight is the understanding of resilience, that is not necessarily looking to disturbances, but also on opportunities to innovate and bounce forward. And we also talked before, during, and after the event. The second point is the use of triggering questions and give a critical view. We have the plans. Do we need to revise? Do we need to reorganize? How we can increase the adaptive capacity? How we can change as new information come at hand? And the same point, and the last point, is the connection between resilience, innovation, and empowering citizens. So we have now these 3 points, and we have some questions here. So
yes. The first one is from Matt Brandlett. He asks about managing uncertainty, steering through the fog, and how do we address the trade-offs and controversies about proposed treatments and the trade-off of delaying until it's satisfactorily tested versus deploying what may look promising given uncertainty. If you look at the other list of 10 relative to the medical world, this is directly related. It's actually number 10 on the list, right? It's directly related to what Eric started on the efficiency thoroughness trade-off. When we go back to our essentials of resilience, and fundamentally it's about multiple trade-offs. So it's not just how you adjust on one trade-off dimension, but how that works relative to others. And the key thing, and we've actually seen this in Dave Deary's dissertation work on an aviation organization's response to Hurricane Sandy, a large-scale extreme weather event, you need to be highly responsive to the emerging needs, information, conditions, and changing threats. However, you still need to cross-check, corroborate, follow up, and assess that actions being considered do not have offsetting negative side effects. Right, and Deary's work that's been reported at our biennial meeting, all right, talks about ways they reconfigured their operation, the middle of the organization to the sharp end, and from the middle up to the top of the organization, in order to solve the speed thoroughness trade-off in a new way, so that you don't miss negative side effects. In examples like responding to Hurricane Sandy, they were able to identify that actions that made sense from one perspective or one place or one function turned out to have side effects that would have made things worse in important ways for others. And so by creating new forms of horizontal communication that are fast, they were able to quickly identify these side effects and modify the plan in another way. So they had to replan the replan, so to speak, in order to do this. So we have to be highly responsive, but we can't sacrifice thoroughness completely. We have to achieve it in new ways. What gets sacrificed is resources, money, right? Those things all go up. Now, the question really comes, can the various parties who provide treatments, run the tests, can they reorganize and move forward? An example here in Ohio is Battelle Research Organization has come up with a UV light mechanism to disinfect surgical masks and do that at scale to overcome the protective gear shortages, one facet of it. How do we roll that out And there's been a few bumps and burps as they get authorization and move through things, yet they're still moving very quickly to be highly responsive to meet this shortage before a surge overwhelms the frontline healthcare workers in Ohio. I think the next question is for Bruria.
Sorry, I had to unmute. I saw that there was 2 questions about the scales that we're using and how did we to measure resilience, and how were we actually able to demonstrate differences that appear during the present coronavirus crisis. So we're using validated tools. For example, for the individual resilience, we're using the 10-item brief resilience tool that was developed by Connors and Davidson. For the community, we're using the CRAM, which was also the brief 10 items. And for the national, we're using a scale which was designed by Kimchi and friends. And these are actual tools that have been used for many years already and have been validated in other periods of time. Now, what we are doing in Israel from time to time, we built the baseline level. And every time that there's some sort of adversity, sometimes it can be a crisis due to security reasons. At this time, it's due to a health crisis and so on. We are measuring it, and then we have the ability to compare what is happening, not only what is happening to what, for example, the baseline level or the level in 2018, but actually what is happening now in the midst of this crisis, because things are changing according to either the trajectory of the crisis itself, the number of ill and the mortality rates, and also according to the different measures. At first, for example, the public was allowed to go to work, and then they said, well, let's do it. Only 50% of the people can go to work, but those who were actually may have been in the midst of someone who was exposed, stay for 14 days at home. And now more or less 75% of the population is under lockdown. So we need to measure that in the different time frames and actually see what are the changing levels of the resilience in each and every point of time. And according to the findings, we can interject into the policies that are transmitted to the public needed information, give them, as I said before, empower them according to what we identify as elements that make them apprehensive. For example, if we found that the problem is leadership, then this is something that we put our efforts in. If we find it's information, or they're looking for social cohesiveness within their immediate community, we can focus on that. That's the advantage of having a scale that you can actually use over time and use it as a support system for modifying the policies.
The next one comes from Sean Weil in Boston, asking about how do we influence upwards when we see higher levels of society behaving in ways, given what we know as scientists and researchers, that are counterproductive or ineffective. And he asks, are the solutions going to be emergent from local or community levels? Well, the best thing, and this also addresses the next question from Milena, about are we being resilient? And the issue is the people under stress, in the roles that are under tremendous stress, are going to drive adaptive response. Adaptive response is going on, and normally in these kinds of crises, you tend to see the adaptation work fair kind of middle out. People at the closest to the stressors are just trying to cope with the stress of the situation. People further up in levels can often be disconnected in ways and slow and stale at best, right? So this applies no matter what. What really plays out is in the middle, and that's where you see the hospital systems adapting, the other jurisdictional organizations trying to adapt to provide help. Now, in places like the US and the UK, where you see the shortages of protective gear and testing, we're not seeing other layers in society be able to connect to that in a timely way at this stage. Now, the horizontal communication, ad hoc, emergent, innovative horizontal communication drives this. If you look at the other list of 10 points, you'll see this is enormously powerful of what's going on, where doctors are sharing information through their personal networks, through their professional societies, the critical care medicine. So the fact this is a rolling series of outbreaks means they can get prepared. They also understand this is a novel disease that requires them to adjust many aspects of their practice in providing help to patients with the form of acute respiratory distress syndrome that COVID-19 creates. So they're learning and they're poised to learn. And I will, as one physician commenting on getting ready said to me, right, it will be very interesting to see how well we adapt and how well we basically digest information, analyze it, and get it to the bedside. In other words, after they've been adapting, they also recognize they're going to need to adapt another round as they dig in when they experience the level of surge that's going to hit their particular hospital or region. So that horizontal out, and it's an example that resilience is, as Richard Cook likes to say in terms of his talk on bone, is resilience, right? It's there. Some people will demonstrate it in a crisis. The issue is, can we synergize enough of the others to work with them effectively?
I would like to add something concerning that. We know that resilience is a huge word. There are so many definitions to resilience and so on. So actually, in order to answer the questions, we first have to define what type of resilience we're talking about and at what point of time, because we cannot answer globally, yes, we are resilient, or no, we're not resilient at any point of time. And even if we think that at one element we're resilient right now, very quickly it might change. There is one thing that I think that has been shown very nicely in this COVID outbreak. And maybe for me, it's the first time that I see it as actually materializing within the crisis in a huge way. And that is working together. I mean, the coronavirus doesn't recognize boundaries and borders in any way. And I must say that in a huge way, neither do we right now. We're building now a different kind of border, or a different kind of boundary. Rather than borders between nations, we're trying to build a border between humanity and the virus. And in order to do that, we see a lot of collaborations. I have a lot of connectivity with colleagues from China and from what we see here, United States, Norway, Israel. I'm sure the participants are from different countries and so on. There's a lot of sharing of information that makes us able to process data very, very quickly. And we also have in our technological world, also the AI, the artificial intelligence, which helps us to sometimes process it even quicker. And in that sense, I think that the international community is getting to be much more resilient than we were before.
So Tanya asks about, does the focus on the front lines and showing support for the front lines from other parts of society reinforce a heroic response at the healthcare worker level to the exclusion of a more holistic understanding of our systems at a societal level? I might get a little emotional here. We call our consortium with industry on a completely different theme in resilience, snafu catchers. Snafu, situation, normal, all fucked up. There's no time to be polite here. The scenes in Italy, Spain, starting in the UK and places, in New York, in the US, I'm sure it was that way in Wuhan at the initial outbreak, right? Snafu, that's right. The people on the front lines are getting screwed, right? Let's be blunt. There's not protective gear. They're putting their lives on the line. retired doctors, older, are coming back, volunteering to help. What's the rest of us doing? Right? I mean, in the end, they will step into the breach. And if you look at the blog at Adaptive Capacity Labs, my diary on this, you will see what I explain about what it actually meant historically to step into the breach and put yourself at risk for others. I don't think we can ever pay these people back.
Thank you, David, for sharing, and Bruria. We have a question from Jan Martin, so nice, from our colleague from the Netherlands. And what does resilience engineering say about trade-offs? And we are all experiencing these trade-offs. And also Milena talks about what is happening in transportation and all the sacrifices that are doing at some point, another point. The healthcare professionals in Norway, they were very concerned about bringing the sickness to their houses and how they can impact their families too. So the effects of the economy is one of the priorities in Europe, how we will cope with that, all the people that is unemployed now and so on. So what are the effects on shutting down the economy versus not completely shutting down the economy? So that's something that will, Bruria, you want to comment on the question from Jan Martin? I think Jan Martin will have enough to comment himself too. So. Bruria?
I couldn't see the question. You're talking about the questions of the trade-off?
No, the question Jan Martin, yes, from Jan Martin Skragen.
Yes. Well, I think at this point, we're trying as much as possible to try to focus on the necessities, on something that we know right now. That's the most important element at this point of time. And this actually relates back to what David was talking about a few minutes ago about the healthcare systems and the healthcare workers that are putting their lives on the line, if we can call it that. Right now, what we're saying is that everything that we're doing in order to make sure that our healthcare system is strong enough to manage to treat everyone that will need our help. And we know that that is not the case in many of the countries, okay? Even in very strong healthcare systems. So we're trying to do in regard to these trade-offs, we're saying we're focusing on the most important, the most vital at this point of time. And we know that we are waving aside some elements that are going very soon to become a huge problem, because it's not only the economic status and having people unemployed, it's also a lot of elective procedures, for example. So we can say, well, you wait right at this minute because we need the healthcare systems for more urgent care. But looking at time, these are going to become more and more crucial elements, and they're going to put an overload on our system, even after, you know, the graph of the COVID-19 patients is going to go down. So we're going to be in an overload of our systems for a pretty long period of time, which means that, yes, elements that we deemed as very important up to 2-3 months ago now are getting a lesser priority. And what is needed to do, and I think this is being started to getting more and more attention in many countries, Israel included, is side by side by coping and managing the most urgent challenges right now. There are committees that have started to work now, trying to think, first of all, how we can bring back part of the economy, how we can help people while they're sitting at home and maybe not getting their salaries and so on. We have measures such as giving them a defined sum of money to help them right now cope with, again, bare necessities of buying food, of buying medicines and so on. For some people, it's not so easy when they're not working continuously. So this is something that has to be done side by side, simultaneously with managing the more urgent elements. But with time, these planning are going to actually have a more higher priority and higher prevalence of our efforts and our resources that we're going to be putting into them. We have started now. It'll grow in the upcoming days.
So Jan Martin's question gets at the heart and beginning of what we were starting to do with resilience engineering, which is that the trade space is multidimensional. So it's not moving a position on one trade-off, economy versus providing health care to severely ill people, right? That's one trade-off curve. That's not how it works. It's not how it works in biology, right? It's multiple trade-offs. And that's why I talked about when we started this with the sacrifice decision. There's many things we could talk about the sacrifice decision and reconfiguring, right? What do you focus on, right? What do you deprioritize? I just want to comment for right now that what you sacrifice first and what you sacrifice last tells you a lot about the values of the organization, group, entity, unit, nation, jurisdiction, whatever it is. What's your value, right? And if you say, I mean, to me, I cut through all the discussion, and you can watch Sydney, myself, and Tom Seeger talk about the aspects of moral imperatives here. In the end, I cut through it all and say, hey, if you're going to if you're willing to sacrifice other people, what does that say about you as an entity? You know, I can't even comprehend that people could say that. You have to respond effectively to the most severe possible consequences. And that is why the whole thing on the 10 points I went through, and that one of the two documents starts with, what can we do to reduce excessive deaths? Right? And if somebody wants to question that, I don't know how to deal with that. That's not scientific. It's not practical. It's not effective. And it is going to be immoral, frankly, from my perspective. The instrumentality of this is such that the morality and the alignment of effective action go in the same direction. If you overload and slam the healthcare system, they can't possibly do as well for the patients, and you will have a much higher excess mortality rate. Now, the question isn't that we can't explain this, and I could talk for a long time about how these trade-offs work in this particular case and where things should go. We can explain a lot. The issue is, can we take those explanations and turn them into actions, right? And maybe we're not connected in enough or into the right parties and whatever to translate what we understand into actions that would be helpful for those jurisdictions as they reconfigure their relationships and activities. I think there's one other important thing to understand and remember if you go through the other 10-point list about the expanding medical response. The medical system is under 3 forms of stress simultaneously. One is, while elective procedures can be canceled and some other procedures deprioritized, the healthcare practice is already operate under load. They wouldn't be viable from a financial and resource point of view if they weren't busy to begin with. So when you talk to somebody, they always go, and we were already busy. Who are they busy with? Sick people, right? You can defer some aspects, but episodes still occur. You can defer a little bit, but chronic health issues can, when not managed, can turn into acute health issues. So they still have a significant load. Ohio has a nice statistic on how much they have added to their capacity by reducing and transforming to telehealth some of the ways they take care of current patients. The second load of stress is what we all know about, right? How do you figure out how to take care of effectively as you can the people who need hospitalization and intensive care treatment? That is all encompassing. And the nature of the transmission risk means that you need to separate your non-COVID patients from your COVID-19 patients. Again, reconfiguring everything. That's the third form of stress. Everything is reconfigured in order to operate at scale. Everything is reconfigured to deal with a novel disease. Everything is reconfigured in order to sustain performance for the other healthcare needs, even with some deprioritization of some procedures. 3 forms of stress can easily overwhelm, right, a healthcare system. And so making that continue to work And the studies in emergency medicine of large-scale catastrophes is that the frontline people keep trying to do what they can, right? And they reconfigure and they reorganize how they deploy expertise, and they bring in new personnel. They reposition medical students, right? They bring in doctors whose specialty was some other area all of a sudden are becoming respiratory specialists through interacting with longstanding specialists in that area. They're going to keep reconfiguring to take care of the people within them. And our job is to find ways to support the enormous efforts they have to take. And I remind you that most of the information being circulated is pretty off base, off target. It's dilatory, it's just wandering around, et cetera. What we really want to get at is many of the hospital systems are under significant stress in this reconfiguration and preparation phase, as even early in COVID-19 patients showing up at the hospital and only a few in the ICU. The signs of stress on the system emerge relatively early, and the adaptations going on are profound in order to make it continue to work.
Ivonne, you're mute.
So now it's okay?
Yeah.
Now it's okay.
Yeah. So just the last question, and I will take advantage that Bruria is here from Matt, that can you talk about the difference in the nature of the information we are receiving? How can we learn well from this?
Yes, I will, but very briefly, I have to comment on something that David has said, up to even the point saying that it's immoral to maybe make different prioritizations and so on. And I have to tell you, and I'm coming from the medical, from the healthcare systems, this is what triage is all about, triage of people who need your help. Because you don't have enough resources versus the need, you're actually saying where I will put my resources, which means I'm not going to give a priority to some of the needy populations. Unfortunately, this is what this emergency is also all about. We can see it in Italy, we can see it in Spain, and hopefully we will not see it for much longer. But life is complicated. Now,
so you're absolutely right that that's why the excessive death rate goes up, is because they have to make these very difficult triage decisions, and that will be with us in many, many ways. And I think it reinforces, I get emotional about this stuff, but it reinforces the point underneath it that we want to provide the assist from the other layers and interdependent groups to give the healthcare workers a fighting chance to help the patients and the patient load, and to not leave it where they simply have to struggle through and make these terrible choices.
You're right, right. I want to relate to the question of Matthew about the differences of the information that we're receiving versus their effectiveness concerning the outcomes. And this is actually one of the main elements, I think, in which highlights the importance of collaboration between the different stakeholders, also between the academia, the scientific world, and the practitioners. What we are doing now globally, not in one society or not, we're looking into all the different models of response, including the testing, but not only the testing, and seeing versus the outcomes, the graphs of the rising morbidity and the rising mortality and so on, their effectiveness. So for example, if we look at what are the measures that were being implemented, vast testing in South Korea, in Singapore, in Hong Kong, and so on, versus other models that used, like my country, that used in a very extensive way a lockdown and not having people even go more than 100 meters from their home. And then you look at the effectiveness over time. We can't do it in a day or two. We have to look into, this is something that during the outbreak we have to monitor. And then we can understand understand from it what works better and take into account the different, the countries, the different governance elements, because not every country finds it as easy as other countries, for example, to implement very extreme measures and so on. But we can look to see what is more effective. For me, for example, I find what is doing in Singapore something which is we can all learn from, or from South Korea, okay? And it affected, for example, what is happening in my society. We started from less than 500 testing a day to more than 10,000 testing a day, because of what we saw, the effectiveness of that. So the main thing is collating the information together, and all of us can use it in order to see how it impacts on the outcomes.
That's perhaps something that you and Matthew can work together, Bruria. So I would like to conclude this talk and invite people to contribute. This is going around the globe, is the idea. Next time is Johan Bäckström and from Sweden, Tarcisio from Brazil, and Martina from Italy, to be confirmed, Martina. So the 20th of April, this started with a small conversation with Dave, and then he escalated with this idea, and people is very welcome to contribute. Many thanks to Dave and Bruria for sharing their knowledge, and this will be recorded and available for everyone. Okay, thank you.
And thank you, Ivonne.
Thanks, Ivonne. Thanks, Bruria.
Bye-bye, everyone.
Everybody. Good luck to everyone.
Amen. Bye-bye.